More a comment than a question. I think one of the barriers to reaching out to the key populations that we had with HIV is the fact that all these groups of key populations have been classified as criminals the whole time. And I hope that maybe we have some policy of people who have power over policy making in the room. I think one of the moves that we have to make as pro-public health workers is to try and decriminalize all these, from the sex work to the consumption of these drugs that are now illegal, to men having sex with men, which is still illegal in a lot of countries, especially African countries. And that would be a huge step forward, and then we can have services targeted towards them because they will be legal.
Yeah, I totally agree. My talk was indeed in the criminalization of those that are most at risk of being infected and to infect others. Actually, I was in Moscow last year. I also spoke with Medvedev or his assistant, because you know the policy that they have. I don't know if we have Russians here about IV drug users. They just put them in jail, and so I just try to explain, for example, that I'm not understanding what they think about that, but I know their policy, but the risk is what happened in other countries, that you will have a problem with your general population, because of course IV drug users also have sex sometimes. And so this is what happened in Italy, for example. We started with a huge IV drug users epidemic, and then it's just spread in the journal, of course, in a smaller scale. But in the problem of laws and criminalization of these groups is dramatic, because this is also what will stop us to reach the targets we have.
So, Stefano, I know you were involved in developing the guidelines for HIV from the beginning, and can you share a little bit the tension between having proven interventions and taking an assumption that it will work and act upon that? Because I do have the feeling, but correct me if I'm wrong, that the hepatitis field is a little bit towards proving things before trying, almost, right? I mean, we have to close the latest gaps and everything before we start mass action, but you can also do public health and learn while doing and while making some mistakes. But
yeah, in fact, I
see what I mean?
We had a terrible debate when we produced the HIV, because of the evidence that was missing, even to go to 500 CD4, and I was the chair of that guidelines. We had an incredible, and then I don't know why something went a little more relaxed. We went on treating everyone. That I understand the operational advantage, maybe, but there is a problem of equity, there is a problem of resources. I was not totally in favor, because the evidence was a little less. Now, for HCV, it looks to me that they just copy and paste. You know, I mean, I'm joking, exaggerating, but it's a little too easy now to, without understanding even the mistakes we did. So, in a sense, is what you are saying. Now, you are saying that they gave for granted something that was, in a sense, similar for HIV. They say, okay, it will work also for HCV, but it's a different disease. So my examples were not saying that it's the same disease. It's different, totally different, or partially different. But it's different. So we cannot just do the same thing. And so that was your question. I mean, you think that they assume things that are not there?
I think in the HIV development, but sometimes also people make decisions on biological assumptions,
yeah,
instead of having to prove it. And I'm just looking at your market, whether that's happening too, or whether you're too cautious to have...
Well, no, actually, my sense with the hepatitis C guidelines is that they've looked at the more recent HIV guidelines and made recommendations based on limited data.
Yeah.
The issue for me is not the WHO guidelines, it's whether or not in a country's response to those guidelines, they'll say that's a low conditional recommendation, low quality evidence, I don't have to act on it. So it's to me not the guidelines, because we made recommendations, in my view, based on pretty soft evidence, and so we had to make them quite reasonably using the process. Conditional, low quality, which that's a country, a government's response to that might be, oh, I'm not going to do, I don't feel as compelled to do that as if it's strong. That's why, to me, you make the recommendation, then you try and strengthen it to help countries have more sort of confidence to implement. Because there's two things. There's a WHO guideline, and then it's does the country actually implement that guideline, and how do they go about doing that in terms of where they decide to allocate funding? So you know, if I've only got a set amount of money, how am I going to allocate for my country? And so they will take where they feel most strongly they'll get best bang for buck. And so the better information we've got, I think, is important, but it shouldn't stop us. Does that make sense?
Yeah, sure. In that regard, Peter, I think...
Friends, I'm going because they called me in the back. If not, I will lose my flight. But thank you very much.
Thank you.
Take care. Bye-bye.
So Peter, the model that you propose, for it applies for all chronic diseases, right? And I think historically you started with HIV and now you move to hepatitis C because it's close to your genes. But I wonder, are there actually more profitable chronic diseases in comparison to these two infectious diseases?
I wanted to make a remark first, because what we see is that, you know, the response in 2000-2004 was to basically set up some institutions which would provide funding to counter, you know, one of the largest pandemics we've ever seen, HIV/AIDS. Now, in the HIV response, actually, we've created institutions, massive institutions, which are used to that type of environment. And now with the HIV response, it looks like that most people just want to carry on with that structure instead of rethinking, you know, what this disease needs, what type of local plans should be built, and how they should be funded. You know, and, you know, if you look at it from, you know, the source of infection, the pattern of the disease, the way it's treated, etc., it's all different. So there's no rationale to compare, you know, HIV elimination with HIV/AIDS. If you look at it from the ground perspective, from the clinic's perspective, and the country perspective, especially in low-income countries. Now, if you look at disease patterns, if you look at, let's say, chronic diseases, there I think, you know, digitalization will play a bigger role, because there patient self-management of the disease becomes important. Like, for instance, in Mexico, you now have the sugar clinics, which are basically shops on the street, very small shops, where you can monitor yourself, you can measure your insulin, you get some devices, and you get small portions of insulin, and that basically makes the whole disease much more managed much more effective by the patient itself. So if you look at chronic diseases, you know, there you also see that, you know, new technologies and the way patients and doctors and health workers work together leads to completely new models, which are actually already happening around us. So I think, you know, if we think a little bit out of the box, look around us, then we can find models which can actually work much better than in the past.
In that light, I actually was struck by the first presentation, but most of us would agree that a vaccine would help tremendously, if not being essential for global elimination. And there's no funding for this. So could we apply similar, on a global scale, a model? Could you develop a model where you basically, of course it's always certainly whether you will be successful, but entice governments to invest in a fund to develop a vaccine in order to again save lots of money? Is that, should the two of you talk and get into business?
You know, we're a bit advocate of investments, and that, you know, governments should take, you know, away, let's say, those areas of investment where the private sector cannot invest in, so that they basically provide subsidies or mixed with investors, so that these investments become possible. In the last article which was shown are also some new types of diagnostics. Everybody already knows how to make them. You know, there's an investment needed of $20 to $30 million, and nobody is doing it. So there are already solutions there. They need an investment, they need a period of 3 years, and then it can happen. And, even if a solution is not yet there, for the vaccines, we're on our way. For the HIV vaccine, it's not yet clear. But if we create an investable environment where both the public and the private side share their knowledge and resources, then it can happen, and these types of solutions would be great.
Yeah, I would clarify one comment I made about the Hep C epidemic in the United States and the fact that the government's supporting development of a vaccine. Those are not linked, because the development of the vaccine actually began before anyone was aware of this increasing incidence of Hep C infection in the United States. And what drove it is really the fact that there had been development of vaccines in other arenas that have a much lower impact on the health of Americans. So we see a lot of death from hepatitis C. The death rates exceed that of HIV. Since 2007, the death rate has exceeded that of HIV in the United States. And now Hep C is more common than all of the other 59 reportable diseases to our government combined. So the impetus came before. The situation is not dissimilar in other countries in the world. And I think it's important to ask, and I said a couple $2 billion, really we know it's been tens of billions of dollars to get the drugs we have, but I think if we saw even a fraction of that and invested in efforts to develop a vaccine, it is possible to develop a vaccine, and it could be incredibly important.
So we agree, but we need some advocates and a business case for it, right, to take this further, I think.
Can I have a comment? I wonder if there is another model that for drugs for diagnostics as well? Do you know of a parallel model for diagnostics? I think it's very important that we have one, because diagnostics are a big challenge now in implementation, and it's an important implementation tool for screening. So I think it's important. I don't know who's doing this, but
I saw my co-chair of this morning had
yeah,
big
from
problem.
FIND.
Yeah, from FIND.
I'm not sure they're doing something similar, looking at the price, the lowest price for diagnostics that might be possible, or have a prospective outlook. I think we should look into this. It's important.
And I think at least what I had a meeting in London some months ago, and we were talking to some of the main manufacturers and diagnostic companies, some of the drug companies, etc. And then we posed the thesis. If you think more about partnerships over the long term, if you look at the investment which is needed on the short term, and then the long earn back period, why don't you go into a services model and then get compensated in the same way, so that a manufacturer and a government and other stakeholders actually have the same interest in the way they earn their money, so that when the money is saved, that actually these models match in terms of investments and the way the health costs are reduced. So I think that some work could be done on that point too. And then I think you will actually see investments on this side, that people will actually be motivated and also be reimbursed for the fact that they make innovations which work better.
Okay, any other questions? In the meantime, we've lost half our panel, I'm guessing.
Yeah.
So if not, then let me just close this meeting.